Good evening, and welcome to Module 2 of our ADHD online course for health professionals. I wanted to make sure everyone is aware that this is a three-part course, and there are many nutrients we didn't discuss in Module 1, and there's some we're not going to get to tonight, but we will get to in Module 3. So just for your reference, we're going to talk about macronutrients tonight, cholesterol and amino acids and essential fatty acids, and a little bit about carbohydrates. And then in Module 3, we're going to talk more about vitamins and minerals, particularly magnesium, zinc, copper, lithium, etc. So let's get started. And one of the slides I've been using for almost 30 years now, understanding the role of nutrition and health is not alternative medicine. We have to make sure our patients don't use the word alternative, and either can we when we're speaking about it, because when we talk about orthomolecular and integrative psychiatry, we're just talking about good medicine. It is not alternative medicine. So the first section tonight is just on diet, and it might seem obvious, and I'll go through these quickly, but for those kind of non-believers or anybody who needs references, they're in the handout. That when I started 30 years ago, we did not have the obvious that diet affects ADHD, but certainly over the past 10 years, we have increasing scientific literature to prove the obvious, and what our grandparents have been sharing with us is diet does affect behavior. And here's a study in pediatrics, ADHD associated with a Western diet of higher fats, sugar, preservative-free. So Western diet compared to a more sugar-restrictive omega-3 diet. This was a very large study, over 7,000 kids. Again, clear and consistent link with increased risk of ADHD with poor diet. 4 times greater odds of ADHD with poor diet. This is some of the studies, a couple more we'll mention, where this poor diet really begins prenatally. Attention Journal, 1,800 kids, 2 times greater risk of ADHD with a Western diet. And more recent study looking at particular components in the diet, here omega-3 fatty acids, higher dietary intake of omega-3, 68% decreased risk of ADHD. Now, the next few slides, the statistics, are kind of all over the place, but when you put them together, you can really appreciate how important a diet has become. Again, another study looking at pregnancy, this beginning to kind of understand the relationship between genetic and epigenetic factors. 83 kids with behavioral problems, conduct disorder, prenatal diet high in fat and sugar associated with ADHD symptoms. This had a indirect relationship with a IGF-2 DNA methylation. More studies looking at, again, younger kids. Here, junk food at age 4 associated with increased hyperactivity at age 7. So just a kind of overview. The literature is clear. There's many other studies, but at this point, when our pediatrician and our colleagues, sometimes our dietitians will share with parents, there's no research to support the relationship between diet and ADHD. I think we can quite clearly say the research is impressive and has been replicated many, many times. If we take a kind of deeper dive into that research, we're going to talk particularly about our friend sugar and refined sugar as probably one of the most consistent variables. When I gave this talk, it was 1993, probably the first time I gave a talk on nutritional influences of ADHD. I had to say at that time, it was clearly my impression based on my practice that sugar affects behavior problems, but the scientific literature had not demonstrated this. And I used to have a slide that, the research versus parents, because most parents could have taken that step. But the research now has kind of made some of this quite clear. Again, just a few of the studies I'll go through. Mean age of 8 years old, those that had the greatest sweet tooth, highest incidence of ADHD, 4 times the odds of having ADHD. Again, some of these numbers are impressive. And most of the literature around sugar focuses on what we call sugar-sweetened beverages. This is a study from 2017. And here you can see the amount of sugar-sweetened beverages consumed. First of all, they're increasing. Many people believe directly related to the obesity epidemic. 2/3 of kids aged 2 to 19 consume at least one sugar-sweetened beverage on a given day. 30% of 2 or more sugary drinks a day. So what does that mean for our ADHD and kids with ADHD? Well, we have literature from around the world. Here in Norway, 15 to 16-year-olds, increased risk of mental health in general, and then a kind of direct dose relationship between hyperactivity and the number of soft drinks consumed. This is one of many slides where we're starting to see a direct correlation. And then as we kind of think about sugar-sweetened beverage, it's not just the Coke and the Pepsis. Our energy drinks are being dramatically consumed by our youngsters. Certainly many of our ADHD kids who are looking for extra energy, extra caffeine, and even the juices or the smoothies or anything in a bottle with the word juice in it is essentially what we call SSB, sugar-sweetened beverages. Some of our sweeter drinks have more sugar than colas and sodas. Again, study from a couple years ago in a major international pediatric journal, risk of hyperactivity and inattention increased by 14% for each additional sweetened beverage consumed. And then it gets pretty dramatic here. 173 kids with ADHD, 159 controls, increased 36%, 1 to 6 servings a week. But for those parents or kids that are getting more, a dramatic 400% increased risk for ADHD in those who consumed at least 7 servings per week. Now, if you first read this quickly, you might have thought 7 servings per day, but we're talking about per week. So this is just one sugar-sweetened beverage per week. There are lots of things we'll talk about in terms of blood sugar and refined sugar. A couple things that are obvious, but just to mention, when you talk to parents, I describe refined sugar or these sugar-sweetened beverages as nutritional vacuum cleaners. Not only is the effect of the refined sugar, but it kind of robs the body of B vitamins to help metabolize the sugar. Usually sweet foods in nature has the natural B vitamins that our body can utilize, but a B complex is, most of the B vitamins are depleted with overconsumption of refined sugar. So we have this rampant increase in nutritional deficiencies around the B vitamins. And then something I'll be talking about more, we talk about nutrients, is phosphate. So what is in all the sodas is phosphoric acid. And this is a woman, she was a pharmacist in Germany who was trying to struggle with her child's ADHD. And she started to understand the relationship between phosphorus lowering magnesium, and the high consumption of phosphorus in our Western diets, particularly with sodas. And she was able to cure her son's ADHD and been writing about phosphates in ADHD. So I believe one of the concerns about the overconsumption of diet sodas and regular sodas is the high phosphoric acid. So sugar-sweetened beverages are related to ADHD, the sugar and the phosphate. So now we're going to try to understand the sugar part of it. Old study in the 70s looking at glucose tolerance to a couple hundred ADHD kids. And here, almost 75% had abnormal glucose metabolism. And one of the more common things that we find is this reactive hypoglycemia after consuming refined sugar. When blood sugar is low, we've all felt it, we've all seen it in our spouse, our friends, our children. We might get a little irritable, a little restless, and we'll see how ADHD kids have a more kind of robust, unique response. But early on, we had this relationship. This was the same years we were talking about research with food allergies and ADHD, largely ignored by our colleagues. And then in 2004, this is Dr. Lacey. This is her thesis report that she sent to me, and she wrote a book. But she looked at 29 hyperactive kids. She did lots of objective functional medicine testing. But I just thought these are very nice graphs of the 6-hour glucose tolerance test. Because if you see the normal curve in the shaded areas, and then the dark lines kind of above and below, and what you see in these samples of just these random 6 kids is all the curves were abnormal. They differed in their abnormality from spikes too high to too low, but there was nothing considered as normal. And that's pretty much what you'll see in practice. You don't always get classic hypoglycemia. If you send them to a lab, I routinely do not send these kids to a lab because based on both the literature and my experience, I believe that they have a difficult time regulating glucose. We'll talk about how it affects diet. And these are her studies, again, Dr. Lacey. And I believe this, again, 95, by Dr. Gherardi, who was at Yale at the time in a pediatric research journal. I thought one of the most significant papers that I read on ADHD in my training, in my early years, but was also completely ignored by the pediatric and child psychiatry community. Here, in a very meticulous, detailed research study, he was not an alternative doctor, he was a pediatric researcher from Yale. He looked at the same 5-hour glucose tolerance test, 17 kids, and not only did he monitor blood sugar, but he monitored epinephrine and norepinephrine. So what he was able to show is this blunted kind of catecholamine response. So 50% lower rise in the epinephrine in the ADHD kids. The norepinephrine also was lower. So what happens? We have this incredible ability to regulate our blood sugar. If our blood sugar starts to dip, we're going to start producing some epinephrine and from our adrenal glands. And as we produce epinephrine, we're going to regulate our blood sugar, and we're going to not have the kind of dramatic ups and downs that you see in some of these ADHD kids. So what Gherardi was able to demonstrate that our ADHD kids, they dipped lower. The epinephrine not only was not being able to respond in the same way as it did in normal kids, but the blood sugar dropped to lower levels. And then you get what Dr. Lacey found, sorry to go back and forth, but the attention span, the headache, the drowsiness, and the temper tantrums. So, in summary, our first macronutrient is carbohydrates. I believe for ADHD, it is critically important. A big part of our job is trying to get our parents to understand these kids need more protein. There's no particular laboratory testing that I do. I assume that most of my kids do not regulate blood sugar well, so we're essentially, as best as we can, put them on what you and I would consider a high hypoglycemic diet, smaller meals, more protein, and as dramatically decreased refined sugars, particularly the sugar-sweetened beverages that are being consumed in all these hidden health drinks where they plaster the term juice all over it. There's no side effects for a modest protein diet, and there's certainly no side effects for eliminating our sugar intake. So fats and lipids, I like to call it the fats of life. And I start off with cholesterol. We don't have a lot of time to go into it tonight, but I believe it is one of the most significantly underutilized, underappreciated tests for treatment of psychiatric illness. And I'm not talking about high cholesterol, I'm talking about low cholesterol. Cholesterol is critically important for the functioning of all cell membranes. And in the brain, it helps, there's these cholesterol rafts that help the serotonin receptors. And if there's not adequate cholesterol in the body, in the brain, we have higher incidence of major psychiatric illness, including suicide, aggression, depression, anxiety. We have literature on low cholesterol and addiction, low cholesterol and school suspensions, and the most dramatic literature is suicide and aggression. When I'm talking about low cholesterol, I'm not talking about the dietary intake of somebody who might be on a restricted diet, a vegan diet. I treat anorexia, where the intake of cholesterol and fat have minimized for years and years. They do not have low cholesterol, and it is likely a genetic kind of biochemical difference. Most of these kids that we're seeing with very low cholesterol have cholesterol levels under 120. We've seen total cholesterols between 80 and 120, and again, not related to dietary intake. These kids are having McDonald's hamburgers, eggs, bacon, plenty of fat. There's a genetic difference. But what I can assure you is, and the research is quite substantial, is low cholesterol under 140 has these higher rates of psychiatric illness. For our purposes tonight, we talk about ADHD. The low cholesterol kids, the 80 to 120, 140 even, these are the very aggressive, impulsive ADHD kids, often prone to addiction. And this is a subgroup of kids that I've seen very prone to marijuana abuse. For some reason, marijuana is profoundly therapeutic, so they get quite addicted to the feeling. We use increasing cholesterol in the diet as well as cholesterol supplements. And as cholesterol levels go up, sometimes the addictions decrease, but certainly the level of aggression goes down. That's all we're going to have time for. The omega-3s here. We're all aware of every aspect of neurotransmission, from synthesis to receptor function to membrane fluidity, is based on the functioning of the omega-3 fatty acid. It keeps the membrane fluid. And here you can see those little yellow things in between the receptors are these cholesterol molecules. The research is kind of broad, extensive. We're going to talk about ADHD, but in terms of the ability for our psychiatric patients to have essential fatty acid deficiency, really cuts across all of our major psychiatric illnesses. The important part, as we're discussing with parents, is that the term is we use it takes 12 weeks to change your oil. So looking at whether it's increasing cholesterol for the low cholesterol kids or increasing omega-3 polyunsaturated fats, it can take 3 months. We don't get this rapid response. So parents have to be patient. And oftentimes, if it doesn't help in 30 days, people throw away the bottle or don't buy it again. and just report that these nutrients are helpful. It takes time to change the oil. There are a couple ways the literature has understood where the omega-3s, the EPA and DHA, play a role in the central nervous system. First of all, DHA facilitates serotonin receptor activity, again, contributing to that membrane fluidity. And EPA particularly promotes the release of serotonin. And we have omega-3 levels correlating with serotonin metabolites in the CSF. You know, for our ADHD kids, we have many, many years of research looking at blood levels, omega-3 blood levels. This study looked at lower levels of DHA associated with reduced memory, working memory, oppositional behavior, and reading ability in kids in the general population. This was levels looking at omega-3 in kids with ADHD, 38% lower. This study, published in 2014, was a meta-analysis of 9 studies, almost 600 individuals. So omega-3 lower in the blood levels with kids with ADHD. Here they separated EPA and DHA. Again, this meta-analysis in 2016, 41 studies, DHA levels lower, EPA levels lower, ADHD versus controls. If we had the low blood levels at baseline, we see omega-3 supplementation improve symptoms. Part of what we'll talk about at the end of this section is how do you know who to supplement with, and part of the focus of these 3 modules in this course is the objective testing, looking at the individual. I'll share with you statistically, we see a percentage of ADHD kids with low levels, a percentage of kids responding, and only with kind of our objective testing can we actually predict how we can develop these personalized treatment plans, knowing who's going to respond and who's not to. We'll come back to that. So again, here we have intake. This is, you know, a really important slide because these were what we call blood levels again of omega-3s, the DHA, the linoleic, and looking at the omega-3, omega-6 ratio. But here they were actually able to look at dietary intake. So there was no difference in the consumption of the omega-3, the omega-6 in these kids with ADHD and without ADHD, but the blood levels were lower. And I think that's really important for our parents to understand, and certainly as clinicians that we understand. For so much of what we're talking about, it's not always related to dietary intake. There are genetic variations that affect the absorption and utilization of many of these nutrients. Not that we can routinely do some of these genetic tests. We'll be talking about some tests we can do, but these are 2 studies. Well, one study we'll talk about where there was we were able to look at this genetic difference in fatty acid metabolism between those with ADHD and those without. So there was a polymorphism in this fatty acid desaturase gene that was different. And here's what they found is these kids with ADHD were 60% more likely to have that polymorphism for that particular fatty acid desaturase gene. So that gene is how we incorporate fatty acids into the cell membrane. Again, not based on dietary intake. So we have low levels in the blood. We have some studies looking at dietary intake, and then some of our newer studies really questioning dietary intake being the variable. So what about supplements? These are a summary of some of the supplement trials with fatty acid. Many of the supplement trials, most of the supplement trials, do not directly correlate with whether they had blood levels or not. Really important. And even without the correlation of deficiency states, you see pretty significant events. Participants 700, 1400. This meta-analysis was hard to calculate the numbers, and really improved clinical symptoms in these kind of meta-analyses. So meta-analysis of omega-3 supplementation. And then some specific ones the last couple of years. And it's important to look at the amounts. Every study is going to pick a different amount, and it's confusing for us as clinicians. Supplement companies might just pick one study and use that amount in their marketing. If you took 10 studies on omega-3 supplementation, you'll see 10 different variations. But here, relatively low dosages, 650 of DHA, 650 of EPA for 16 weeks, and improved symptoms of ADHD. This is one of a few very important studies because it really reflects my clinical experience, because some of the early studies when I first started showed better response for supplementation with omega-3 and omega-6. And here, not only was EPA and DHA, but 60 milligrams of GLA, essential omega-6 essential fatty acid. 3 months of supplementation, improvement in, as you see, reading, spelling, and ongoing progress. My clinical experience is oftentimes these are not pure omega-3 deficiencies, and many of these kids do better with omega-3s and omega-6s. A placebo-controlled trial of EPA and DHA for 4 months. This was only interesting because it was crossover design, meaning at times they got placebo, at times they got the fish oil, and again, improvements in our variables with ADHD. And just a few more, and here's some more lasting effects. 6 month, again, relatively low doses, 300 DHA, 200 EPA, alpha-linolenic, found in flax oil, precursor to EPA and DHA, and pretty dramatic results, 42% decrease in externalizing behavior and 68% in some of the internalizing restlessness. And the next slide, children continue to benefit from supplements after stopping treatment. I think this is really important when we talk about omega-3 supplementation. In many of the studies, anxiety, depression, the one that I'm most impressed with was the early onset psychosis study, where they gave omega-3 supplements for just 3 months, and they followed the kids for 7 years, and there was a decreased symptom presentation, decreased use of antipsychotics, just with the 3-month supplementation. So here we see also continued benefit after the supplement stop. Our body has this really dramatic ability to utilize omega-3 fatty acids. I used to test essential fatty acids on everyone, and within months of taking supplements, we saw dramatic increases, and we're able to sustain those levels for a period of time. Just another way of looking at ADHD symptoms, working memory, excuse me, and these were kids treated, again, higher EPA. If you read the literature, you're going to get both doctors, supplement companies, and papers saying EPA is better, DHA is better, and I will share with you my thoughts in a bit, and we can get right down to pregnancy and infants. These were kids, low birth weight, very tiny doses of DHA from 1 week after birth until 9 weeks, and sustained attention and development based on rating scales up to 20 months. So there are also research looking at medications. The first study looked at those that didn't respond to medications, omega-3 supplementation, and improvement in symptoms. So again, one of our markers of essential fatty acid treatment could be non-responders to medication. I'll continue to repeat some of the things I had said previously. Kids that don't respond to medication also have elevated levels of HPA and or elevated copper levels and or low magnesium level. And then, our last medication question, for all the nutrients that we'll talk about during this entire ADHD course, they all can be utilized with medications, be it stimulants or not. And this study a couple of years ago demonstrated that omega-3 supplementation with essential omega-6 supplementation, they were able to lower the doses of the medications. For me, I'm not as hung up on the dose of the stimulant. I'm not sure 5 milligrams is necessarily better than 10 milligrams. To me, the most important point is the last line in this slide, the less frequent side effects. So the dose, I know parents get very hung up on the dose. I want my child on a low dose of a stimulant or a high dose of a stimulant. It is meaningless. There's only an effective dose or an ineffective dose or a dose that causes side effects. What we find throughout this course is nutritional interventions, understanding the gut will cause less side effects. And here, omega-3, we're able to decrease doses of medication and decrease side effects. Really, really important as we talk to parents. So this is, how we all feel as we begin our journey, trying to get through the literature, reading articles that contradict each other. And, I will share with you my thoughts. And I guess I'll go back and forth between our summary slides for each section. Laboratory testing. Ideally, I would like to do essential fatty acid testing on everybody that I see in the office. I try to, it's not always feasible. There are some blood spot tests, although many people find the finger pricks even more painful than the blood draws. Dietary intake not being relevant. It is ideal. It amazes me. I have kids eating fish on a regular basis and have low levels. I have kids that have never touched fish, nuts, or seeds, and they have normal levels. So testing is helpful if you can do it, essential fatty acid testing. The supplements. You do not want to have your patients buy essential fatty acid supplements, from any grocery store or health food store or supermarket or drugstore. You want some of the higher quality supplements where they are going to remove toxins, particularly distill from mercury. You want high quality fish oil supplements. If your patients tell you they burp up fish oil, it's usually a bad supplement or they don't have adequate digestive enzymes. If the supplements smell like fish oil, it's a bad supplement. For those very sensitive that do burp up fish oil, they taste, you can have them put the capsules or the bottle in the freezer. And if you take the frozen fish oil, by the time it gets to your small intestine, it'll be easily absorbed and you won't have any aftertaste. If I'm treating somebody with ADHD, certainly treating someone with a deficiency based on testing, I'll use EPA and DHA and GLA, usually a 2-to-1 ratio of EPA to DHA, and usually, 60 to 100 milligrams of GLA at least twice a day. Flax oil is fine. Some of the earlier studies on depression and omega-3s were on flax with dramatic results. I have seen better results with fish oil. Krill oil, I like as a maintenance supplement because there's lots of phospholipids, lots of sources, but I just haven't found it to replete essential fatty acid deficiencies as quickly as I have the omega-3s. The liquid fish oils now, there's a number of supplements where it essentially tastes like water. You can't taste like fish, but it is really a dramatic, quick way to increase, much more concentrated and a really nice way of increasing omega-3s. So, essential fatty acids, side effects, I have not seen any other than that rancid taste for poor quality supplements. I do not recommend high dose fish oil The early studies in psychiatry, the first study was done on bipolar patients. They were given 9 grams. It was just randomly picked a high-dose EPA with 9 grams. I've seen terrible side effects with dramatically low levels of GLA and DHA and depression from high-dose EPA. So my doses are 3 grams, occasionally 6 grams total a day if someone's deficient, monitoring over time and decreasing to what we would find if we ate a high fish diet. We got to be careful kind of playing with Mother Nature unless we understand that we're treating a deficiency state. The last thing I want to say about kind of fish oil supplements or essential fatty acids is in the literature now. I hate to be a conspiracy integrative doctor, but there's certainly a large community of physicians that aren't interested in integrative medicine and trying to discredit this work. And some of the headlines of some studies that I've seen are, essential fatty acid deficiency not effective in the treatment of depression or the treatment of ADHD. And those articles, sometimes they're meta-analysis, but the articles are not poorly written, but they're emphasizing the wrong heading. And what they're trying to do is discredit omega-3 and understanding essential fatty acid in mental health issues. But what they're neglecting to say, and what is important for this course and all these online courses, is everybody's different. Not every child with ADHD has an omega-3 deficiency. So if I gave 100 kids omega-3 supplements, I would not expect 100 of these kids to throw away their Ritalin and completely be cured, if you will, of their symptoms of ADHD. In those 100 kids, there's going to be a large subset that would benefit from essential fatty acid deficiency, and a smaller subset where that essential fatty acid deficiency could be the core symptom. And that's why this headline, essential fatty acid deficiency, doesn't help, because not everybody who took the supplement was improved, is really a disservice to the field and a poor understanding of both health and biochemical individuality. So we could go on, but I want to get to probably I think the most important topic in understanding how to treat mental health problems, be it ADHD, depression, is understanding protein digestion and amino acid precursors in a relationship to neurotransmitter synthesis. When we think of psychiatry and we think of psychopharmacology, we're prescribing medications that manipulate or change neurotransmitters. We don't know all the effects, but we know some of the major ones. So we say this one increases serotonin, this one blocks serotonin reuptake, but that's what we talk about. And all of our medications affect these neurotransmitters. And all of the major neurotransmitters, not everyone, but the vast majority, are under what we call precursor control. And these precursors, these amino acid precursors, are obtained from our diet. Okay? And it's really important that we understand that and we treat that. So we have essential amino acids, and tryptophan being one of them. And we've known, these are studies done at MIT by Wortman in the 70s and the 80s. If we increase dietary tryptophan, we can increase serotonin in the brain. And we're going to talk a lot tonight about decreasing dietary tryptophan, and we can decrease serotonin in the brain. And this is very, very important to understand. Throughout these online courses, we'll be discussing this concept, of these amino acid precursors, the vitamin and mineral cofactors to support these neurotransmitters. Here you see the precursors here, phenylalanine, tyrosine, phenylalanine being an essential amino acid, being converted to dopa, and then dopamine with our vitamin and mineral cofactors. Here's a schematic. So there are a couple different amino acids that we will be talking about tonight. Here, we talk a little bit about these, what I call free-form amino acids. These are all the essential amino acids. This just demonstrated that these precursors worked within a couple hours and affected concentration, focus, anxiety, and irritability. Specifically for ADHD, one of the early research, one of the few studies looking at amino acid levels in a major psychiatric illness. Again, the most important intervention I utilize in my practice. Here, 28 kids, mean age 10, lower levels of phenylalanine, tyrosine, and tryptophan, and the lower levels of the amino acids associated with more prominent symptoms. Again, not always associated with dietary intake. So this is where oftentimes, I'm spending more time on the gut than I am, as a psychoanalyst, if you will. So the beginning of our digesting of proteins to get to our essential amino acids starts with hydrochloric acid. And it's really critical that we understand hydrochloric acid is a zinc-dependent molecule. It's a zinc-dependent enzyme that helps us make hydrochloric acid in the stomach. The acid in our stomach is sufficient to burn through wood, very, very low pHs, and without adequate acid, we can't digest protein. One of the most important points I can share with you. It is a much bigger problem in our adults with depression, anxiety, and ADHD, but we see it in some of our kids as well. You see that some of the books by Jonathan Wright, amino acid, hydrochloric acid levels decreasing as we age, 40% reduction going from our teens to 30s, and then these sharp declines in the elderly years for anybody over 40. Look at the difference. It's dramatic. And again, without adequate stomach acid, we can't digest protein. Some of the physical symptoms are bloating, indigestion, and heartburn. But those lack of hydrochloric acid also results in very profound psychiatric symptoms, ADHD-B1. So now we want to jump to where this tryptophan depletion kind of paradigm is used. We've done this research for many, many years. It's called acute tryptophan depletion. And we've looked at this in lab animals, and we've looked at this in women, studies with bulimia. And if we, and here's in the next slide, we give these individuals a drink, and the drink primarily has these large neutral amino acids, low tryptophan content, and we can decrease the influx of tryptophan dramatically, 80–90% after 1 hour. So if we use these tryptophan depletion paradigms, we get major symptoms. We get behavioral inhibition. We have poor impulse control. We have aggression, deficits in executive function, learning memory, decreased fear recognition. We have depression. We have relapse of bulimia, many, many symptoms if we deplete tryptophan. These in front of you are the symptoms associated with ADHD. Research studies done repeatedly over many, many years. These are just a sample of some of the studies. This is this acute tryptophan depletion, 24 males. They had high trait aggression. We gave them this drink without tryptophan, more irritable, angry, and quarrelsome. If they had taken tryptophan as a nutritional supplement, they had opposite responses. Again, high trait aggression. Adolescents, again, depleted tryptophan, male patients, increased aggressive responses after provocation. Many, many studies, dramatic studies, but we see in terms of our discussion tonight, ADHD with attention and impulse control difficulties. We have research, many research studies. We put individuals in the lab, give them drinks without adequate tryptophan. We get decreased attention, increased impulsivity. This study looked at a computerized CPT test in 20 adult males. So we talk about acute tryptophan depletion. any academic researcher knows about it. One of the things we don't talk about much is tryptophan repletion. There were very few studies on depression, and we have a few here in ADHD. This was just an interesting study because it looked at tryptophan transport in these kids with ADHD. And again, not always dietary intake, but they were able to demonstrate lower transport of tryptophan in ADHD. We don't understand the mechanism, not quite sure what it is, but obviously important. And then some of the repletion studies, if you will, 500 milligrams of tryptophan, 10-year-olds, improvement in ADHD symptoms, less impulsivity, better ability to monitor facial expressions. And here, tryptophan dosages, we'll talk a little bit about later, 100 milligrams per kilograms per day, improvement on questionnaires, and in a few of these kids, 5 kids, tryptophan equal or better than the amphetamines, the drugs. I typically use tryptophan as a sleep aid, 500 milligrams to 2,000 milligrams of tryptophan for adults, 500 to 1,000 typically for kids. It's been a very, very important part of our treatment model. We didn't talk about, but oftentimes we refer to ADHD rather than attention deficit disorder, a sleep deficit disorder. Sleep difficulties are common. We need to do whatever we can to help our kids sleep. Some of the nutritional interventions from magnesium to amino acids are critical, but tryptophan is a nice adjunct to helping an ADHD child regulate sleep. Many of you know the work of Marty Hines, where he looks at 5-HTP and tyrosine, so that combination for all kids with ADHD, and he had a number of studies published with him and a few co-researchers showing significant differences. I don't often use 5-HTP and tyrosine as a precursor molecule for everybody. That I try to individualize my treatment a little more. Some of the kids do better on dopamine precursors. So just L-tyrosine supplement that we developed actually called Dopa Plus, where it's just a tyrosine, dopa, and a dopamine precursors. We have other individuals that do well on 5-HTP. So the combination 5-HTP and tyrosine has been helpful for some kids with ADHD, but I tend to try to individualize it more based on some of the objective testing that we're talking about. So if I summarize, our work with, amino acid precursors, I can share with you a couple things. The free-form amino acids, meaning essential amino acids with tryptophan, in a powder that's easily absorbed is one of the most helpful supplements that I've used in my practice. It's particularly helpful for individuals with fatigue, memory problems, depression. We base it on a fasting plasma amino acid test, which is critically important. Without the testing, it's fine to use once or twice a day, again, for those symptoms. Tryptophan, we talked a little bit about, 500 to 2 grams, primarily for sleep. I use 5-HTP more for anxiety, OCD than I do for ADHD. And I look at tyrosine as and phenylalanine as precursor molecules to dopamine. And oftentimes we're looking to enhance dopamine to enhance attention and focus. When we talk about utilizing stimulants, we're talking about enhancing dopamine, preventing dopamine reuptake, as well as enhancing dopamine secretion across the synapse. And oftentimes with these amino acid precursors and utilizing some of the cofactors to keep dopamine around the synapse longer can be helpful. So supplementation, Dopa Plus is an amino acid formula, amino replete, and 5-HTP. Side effects. Let me take a minute. I've not seen any side effects from amino replete, the free-form amino acids. Tryptophan, short-term use, I have no problems. Long-term use, I have found tryptophan contributing to inflammation in the brain. So do not take tryptophan long-standing. We can talk more about it in the Q&A. It tends to increase levels of quinolinic acid. For those of you familiar with organic acid testing, tryptophan is a short-term intervention for sleep. We use for 1 to 3 months, for low dose, longer term. 5-HTP, I've seen more side effects. I've seen it more over the past couple of years, where a large part of the practice has been seeing individuals that have not done well with medications or other integrative approaches. 5-HTP is not benign. It can cause agitation, irritability, anxiety. Just like individuals cannot tolerate Prozac or SSRIs, I've just found some individuals can't tolerate 5-HTP. So please don't recommend 50, 100, 200 milligrams of 5-HTP because you read an article about it. I think 5-HTP needs to be started off at very low doses, 25 to 50 milligrams, and monitored and titrated and stopped if there's any signs of irritability. Again, too many practitioners are leaving people on 5-HTP for long periods of time with increased irritability as a side effect. Here you see the precursor amino acid, L-tryptophan, our precursors we're going to talk about in the next section, B6, zinc, folate. But since we're talking about serotonin synthesis, I did want to just mention vitamin D. Vitamin D is a critical cofactor in the tryptophan hydroxylase enzyme, the rate-limiting step. In the conversion of L-tryptophan to 5-HTP. So we need to understand the role of vitamin D in serotonin synthesis. And there are two different forms of this tryptophan hydroxylase enzyme. And between your handout and this slide, it's important just take a few minutes to make sure you understand it, because it just kind of reinforces why it's so important that we look at vitamin D levels. So this tryptophan hydroxylase enzyme, this TPH2, one variant of this enzyme, is only found in brain cells. And when we have adequate vitamin D, okay, we stimulate the serotonin in the brain. This TPH1 is a variant of this tryptophan hydroxylase enzyme that's found in the digestive tract. And we all know that 95% of the serotonin is in the digestive tract. So if we have low vitamin D, okay, we're not going to stimulate serotonin in the brain, and we're going to stimulate TPH1 to make serotonin and cause inflammation in the gut. Really fascinating how nature has been able to kind of regulate our ability to modulate vitamin D, this rate-limiting step in serotonin synthesis. Okay, so we need adequate vitamin D to make serotonin in the brain, and the opposite in the gut. And then, so take a few minutes and just vitamin D activates TPH2 found in the brain. So if we have low levels, well, let's see if we have that. I just have the prenatal slide because when we talk about schizophrenia, we'll be talking more about this, but lots of literature looking at low vitamin D and prenatal risk, and we can see a direct correlation between inflammation in the gut and the brain with low vitamin D prenatally. And here, low vitamin D, increased serotonin in the GI tract, increased GI inflammation. Okay, so we don't inhibit the TPH1 in the gut. So back to biochemical individuality. This is just an elegant study done a number of years ago. Really tremendous variability, 50% based on genetic factors. So we all put our arm in the sun without sunscreen. There's going to be a 50% genetic, 50% variability in how much vitamin D we're going to make based on the sun, or based on our genetics, sorry. So really a very simple blood test. It's covered by insurance. It's critical that our patients understand blood levels. I try to get everybody as close to 50 as I can. Under 30, I treat aggressively. If you do this on everybody with ADHD, you will pick up children with levels of 5 and 7 and 10. What is important clinically is by taking a vitamin D supplement, our patients are not going to feel better next week, and they might not feel better next month. Vitamin D repletion to me is a foundational intervention. When we get adequate levels of vitamin D, you're eventually going to optimize serotonin synthesis, which is great. But what we do is get a foundation where any of our interventions, be it a stimulant, be it a other medication, be it a nutritional intervention, just works better. Until I started optimizing vitamin D, I got this erratic pattern of improvement. Vitamin D, just like B12 and some of these other kind of critical nutrients, are important that is repleted. Patients aren't going to notice the difference necessarily, but as we start to look at other interventions, they'll improve more dramatically. I use up to 10,000 international units daily, vitamin D3. I test and then I retest. So we don't want high levels of vitamin D. People can, again, absorb and utilize vitamin D differently. Give someone the same supplement, their levels double. In a month, you give someone supplement doesn't budge. So you want to check in about 3 months and then taper the dose down with a maintenance of 2,000 to 4,000, but I go up to 10,000 without a problem. The other part that we were going to discuss in this section, I'll go through quickly, is this phytochemicals. Particularly wanted to talk about OPCs and these flavonols that affect brainwave. So we're all familiar with some of these. The ones I want you to remember are the theta waves, which are associated with daydreaming, and beta waves. If anyone's paying attention, you're looking at beta waves. So our ADHD individuals, and we've had this literature for 10, actually more like 20 years, that we know individuals with ADHD have a higher theta to beta ratio. Okay, increased theta, unfocused, and decreased beta. Really kind of important. It is consistent across many studies and all ages. This theta beta ratio, again, all ADHD groups. And what is neurofeedback? For those of you that have no neurofeedback, this is the one slide. It is helping individuals through a computer program, a biofeedback mechanism for the brain, learn to train the brain to do what we're trying to do here, decreasing the theta activity and increasing beta activity, okay? Neurofeedback, decreasing theta, increasing beta. It works, approved by the Academy of Pediatrics, and the improvement was sustained. The training is usually 3 times a week. Oftentimes it's 2 to 3 months. It can be expensive. I did it in my office for a number of years, but here you find improved significantly in academic performance. But what I was able to demonstrate with some original research that we did is we received the same benefits of neurofeedback by supplementing our patients with OPCs. And OPCs, these are the polyphenols I talked about, but just think of the colorful phytochemicals in our fruits, the blue and blueberries, grapes, green tea, red wine, cranberries, plums. And these are really important phytochemicals for brain function. We have research going back many years. Some of the early studies were done with pycnogenol, which is pine bark, which we also have utilized. So with our combination OPC products, we were able to demonstrate that these OPCs do the exact same thing that we see with the neurofeedback program, decreasing theta waves and increasing beta. So improve that theta-beta ratio. We also found OPCs providing other support that we look for with ADHD, improving antioxidant activity. Remember our catecholamine levels that were not regulated well in ADHD? There were some studies looking at urinary excretion, OPCs, moderated catecholamines. When we talked about allergies, I mentioned vitamin C and the blood-brain barrier. OPCs in Europe are used for things like hemorrhoids and varicose veins because it improves the integrity of the blood vessel wall. and also the integrity of the endothelial cells of the blood-brain barrier. And then next module, we're going to talk a lot about zinc and elevated copper. And guess what? OPCs can decrease copper level. So OPCs are an important supplement. Here's the study looking at lowering copper. But in light of time, there's no laboratory testing that I do. I have found OPCs particularly helpful for the inattentive kind of ADHD. I've had patients that's been ordering supplements for years and years because when they stop the OPCs, their inattention comes back. I use mixed supplements. We looked at pycnogenol individually and grapeseed individually when we did the research in the late 90s, and we found combinations to work best. There's a supplement that we did design for pure encapsulations for this purpose called Curcumsorb Mind, with mixed OPCs that we've been using now for a number of years. So I'm going to end our discussion tonight, and I'll take some questions on a really dramatic study by Dr. Galler. This is a pediatrician. She's been at major universities in Boston, at BU, and now at Harvard. But she followed a group of kids who had malnutrition in the first year of life on the island of Barbados. So she had a very well-controlled study. But what they were able to do, which was really dramatic and remarkable, is follow these children for 40 years. So individuals that had an onset of malnutrition came to the hospital for malnutrition during their first year of life. So it was just one insult. And then they were treated and monitored. So they were monitored for, again, up to 40 years. And you see these age groups, 37 to 43. And those kids that had just one episode of malnutrition, 60% had ADHD. I mean, it's really dramatic. And the incidence of ADHD in the controls, that was still high, but it was around 15% in the island of Barbados of these kids that participated in this 40-year study. So when we talk about nutrition for ADHD, tonight, hopefully I demonstrated, I know I went through some of the slides quickly, there's just so much information that diet is clearly shown to have a relationship with ADHD, academic research, nobody can refute. Sugar-sweetened beverages in particular, direct relationship to ADHD. Poor carbohydrate and blood sugar regulation related to ADHD. We get to lower levels of amino acids, poor digestion, lower levels of tryptophan, and our ability to use supplementation also demonstrated in the research. And then I tried to end at looking at a phytochemical that you don't need testing for, that can be dramatically helpful for attention issues in both adults and kids, is these mixed source OPCs that both decrease inflammation, decrease histamine for allergies, and a direct effect on the theta waves, which are those brain waves that directly related to inattention. So lots of information, but more to come in our third module. So again, thank you for this opportunity to speak with you. Thank you.